So I guess
I might get on now.
Hello, everyone. So I hope we are all fed and watered. Now it is 1 and it's time for our next speaker. It's my pleasure to introduce our last speaker of the 2022 AIM Symposium, Dr. Russ Greiner. He is a professor in computing sciences at the University of Alberta and the founding scientific director of the Alberta Innovates Center for Machine Learning, now known as AMI. He has been the conference and program chair for the International Conference on Machine Learning and editor-in-chief for computational intelligence. He has published over 300 refereed papers and patents, most in the areas of machine learning and of knowledge representation, including 4 that have been awarded Best Paper prizes. Please welcome Russ for his talk, View from the Front, working with medical colleagues to produce effective predictor systems.
Like unmask at this point. Is this okay? Is the volume okay? So, thank you for inviting me to this prestigious event. I'm delighted to be here. It does bring back memories because 2 years ago I gave a talk, and that was the day before I started isolating. So this is my first talk, one of my first talks post-isolating. So hopefully that's a sign of good things to come. So I'm going to talk about view from the front. Let me give a little bit of context here. These are incredibly exciting times in mathematics. Almost every day there's another article that talks about the wonders of what machine learning can do. There's a chosen system for diagnosing pneumonia cases by radiologists. The FDA has approved a tool that's been employed for helping doctors diagnose heart problems. Our colleagues at DeepMind have an AKI system for acute kidney injury that finds hard to detect, often fatal problems days before the symptoms have first appeared, what other people can see. A competition in China, they found brain tumors better than clinicians could find them. And my favorite is the tool that's developed here in Edmonton, a urine test for adenoma, for pre-colon cancer. I know our family here is over 50, but those of us who are know about this monstrosity. It's a fecal occult blood test. I'll let you think what that term means if you don't know already. That's very high non-compliance. It's actually not that accurate. How about a tool that actually uses a urine test that can give more accurate diagnosis for pre-adenoma, for colon cancer precursors? Again, developed here, and I was fortunate to be part of this team that did that. Of course, that's in the popular press. You look in the medical literature, look at PubMed, and you'll find, oh, my video. Okay, should my video be on here? I just realized. Should I turn my video on for it? Okay, I'm good. Okay, so okay, good. So sorry. PubMed, I guess already a month old, so already way behind it. They've shown some 81,000 citations to articles that have the word machine learning in the medical literature. As you can see, it's very clearly exponential rise in the number of articles. Of course, that's the world at large. If you look at Edmonton, me in particular, over the last 20 years, I've been involved with a few different projects. Breast cancer, brain tumors, and transplants. But a few years ago, I was on sabbatical and I stopped saying no to cold calls and found a whole wide variety of people who want to understand what machine learning can do for these medical tasks. So I started saying yes and talking to people. I have a whole wide variety of projects to be involved with. So, a quick summary of the type of things: a whole bunch of works in cancers, breast, brain, colorectal, psychiatry, strokes, cardiovascular. Some recent work on COVID. You guys heard about COVID-19? Some machine learning you can apply to that task. You've heard about it. I heard someone said different modalities, clinical features, histologies, different omics, metabolomics in particular. Per task, go from screening to diagnosis to prognosis to treatment management. And for me as a machine learning person, it's exciting not just to be doing the great work that gets applied to medical applications, but also be able to look at foundational topics for high-dimensional data and client data sets, and so forth and so on. So lots of applications. So I might suggest what I've been doing the last 20 years. Someone comes with a problem, and I try to figure out how this collaboration will work. Other of you people here, you've now taken various machine learning classes, including at this symposium, may have some opportunities to collaborate with medical researchers, clinicians, as well as medical researchers, and want to predict some sort of predictor system that can be effectively deployed. So there's many issues in possible miscommunications. This presentation today is designed to help with that, to give you guys some ideas of challenges and approaches, and even some effective narratives that I've developed over these decades. Information I wish I had had when I started this quest many years ago. So this presentation is no theorems, no algorithms, no empirical results, just a collection of ideas that, which you probably already know this implicitly, that might help you in your contacts with future potential medical collaborators. And again, people who are MD, PhDs, this is different hemispheres of your brain can talk to each other as well, right? As you start thinking the different ways to think about the world. So again, this is a talk directed to machine learning people, and I could imagine a parallel session with another person talking about how medical people can talk to machine learning people, but that's not what this point is about. This is how things I've developed to talk to people I'm engaged with. So give me a bit of background. Again, at least people in the room. How many people here are machine learning people as opposed to medical? So machine learning first. Scattering of hands. How many people have a medical background? The same size. Both? I guess that's implicit by the intersection of people. And how many have actually used machine to develop a medical system at some point? Okay, well, I'll raise my hand. I've done that. Okay, for screening or diagnosis and so forth. Again, I want to ask those questions, but again, so I guess I guess a handful of people who could each side of this. Again, my volume's okay. So I'm talking about 3 steps of this type of collaboration. There's a first, I'll very quickly talk about machine learning people meeting the medical researchers, part 1. That'd be very quick. Then doing it, defining the task. That's a lot of work. I'll talk about some of the issues that go into that. And then finally, I'll talk about doing the work itself, goes into that process. So very quickly, there's lots of ways that medical people and machine can interact, depending on how skilled they are in machine learning and how skilled you are in the medical areas. But I'm talking about a particular way. This is a context of an ML naive, a brilliant machine medical researcher who has maybe heard about machine learning, wants to know what the field's all about, and they come and say, here's data, I want to do something with it. So again, it's one of the contexts, and there are others you can think about, but I'll be focusing on that right now. So that's what I'm going to talk about. What do you as a machine learning person do if someone says, here's a data set, let's go have fun. So now for the more direct part, defining the actual performance, defining the task. I'm going to talk about a few issues here. What is the performance task issues and how to do the evaluation. So here's a conversation I've had again and again. I have a data set. Russ, do your magic. I get a little hat. And I say, okay, what are you trying to do? Are you trying to predict the disease or maybe the treatment outcome? Are you trying to predict the treatment's best? Or maybe you want to predict the age of the patient? And what are you trying to do? What is your actual task? What are my options? Well, we do any of these, but start to ask what the problem is. So, as a quote of my colleague, start with the problem, not with the data. What are you trying to do? What are things that will help you in your practice? That's what we should be aiming for. So the goal, I tell my machine learning colleagues, and I'll say out loud, is the goal is a performance system, the system that's going to be deployed, it's going to be used. No one, well, except for me, no one cares about the machine learning tool itself. The machine learning process is something that I care a lot about. The clinician, they care a lot about the learned tool, not the learning process. So I'm going to focus on supervised machine learning with situations like this, where you got data about a patient, a performance system, a system I would have called an expert system back when I was growing up many decades ago, takes this data and tries to find an answer. So that's what we're going to talk about. This picture here doesn't talk about learning. It's the result of the learning process. The input is going to be things like description of the patient, clinical symptoms, omics, images, whatever it is. The output will be diagnosis, disease or healthy, or maybe a particular treatment, the efficacy of the treatment. So those are the type of things that we're looking about. Description of patient goes to some outcome. So I'm going to give 3 themes. I'm going to come back to them again and again. Focus on the performance system. Focus on what is going to be used when this tool is being deployed, because that's a critical part. So in that context of the performance system, there's sort of 3 things I want to mention. The first is association versus prediction. I'll give a narrative to describe that. I'll very quickly talk about 2 other quick topics, which I'll get to in a moment. So first, this idea of association versus prediction. As you probably know, the world that I live in looks like this. I've got descriptions of patients. So here I got 66 patients. And for every patient, I've got some 30 features in this case. These happen to correspond to junctional proteins, but as well as other factors that are women, and trying to figure out whether there's going to be a relapse or not. But this is a world I live in. It looks like this types of description. What do you do with this data? So here I'm giving a narrative to sort of illustrate some of the issues. So what do you do with this matrix like this? Well, if you talk to most people in the medical field trained on biostatistics, they'll say, I know what to do with it. It's obvious. I want to figure out the etiology of disease. I want to understand the disease itself. Tell me the important features. Tell me about what to probe next. What to knock out, what to amplify. So in that context, one easy answer is just looking at correlations of each individual feature with the outcome. And so they find things most correlated, and that may say, we're going to knock out this gene or amplify this substrate. So that's what's typically done. They try to figure out what the feature which is most important. So again, this is what association does. And if you know the term biomarker, that's sort of what the context is, what they're typically trying to think about doing. Another approach, a different approach, is trying to predict not the etiology of the disease features, but instead looking at, can I build a diagnostic tool? So will I have a relapse? This woman wants to know. And the doctor wants to give an answer, hopefully the accurate answer. Hopefully the answer is no, but at least knowing the proper response. So how would you build a predictor? Well, again, if you talk to people in the medical field, they might say, well, I'm doing it anyway. Associations are predictive, aren't they? So maybe I look at a number of lymph nodes. So with number of lymph nodes, you could figure out a dividing line, saying if there's more than one lymph node, say it's relapse, I'll always say no. It's a predictor. Well, what about other? You have 30 features, maybe there's other ones. For example, the concentration of beta-catenin in the nucleus, and build a little model for that, and try to find a predictor based on that. Or maybe look at the tumor size. Maybe that's informative. I'm going to come back in a few more slides. This issue that the correlation of beta-catenin in the nucleus, it's negative 0.019. It's basically uncorrelated. I'm going to come back to that later on. But notice that's a particular predictor you could imagine using. And there's other ones, age diagnosis or P10 or other types of fake features. Chris, this is saying I want to get a single feature. Well, why look at a single feature? You've got 30 of them. What if I combination? So again, now, again, this is part of my narrative is here's a patient. I got 30 features describing this individual. A classifier, I think you really want for your clinic is something that takes these 30 characteristics and does a computation and says relapse. No. So how can I build this type of classifier? Well, one approach is I know everything about the whole process of breast cancer and relapse and metastasis. And I know if this much alpha-catenin is the nucleus, that means it's not where it's jobs on the membrane, and it has P10 to counteract that. And for a woman who's postmenopausal, with this many lymph nodes, and now yada, yada, yada. That's how I can compute it. I know the whole mechanism. That would be great. If we could do that, you wouldn't need a machine learning tool. Unfortunately, we're not at that point right now. We don't know all the processes. So what can we do? Well, remember that data set I mentioned a moment ago? That with historical patients who I knew which of these had a relapse, which did not? Well, machine learning is a whole body of tools that take this information, that take this historical data of describing earlier patients as well as the outcome, and combines them in ways that finds patterns that says, now I know, now I have a classifier that can now be used for new patients. So that's the idea. That's what machine learning can do. And why it's different than the other approach. So to be concrete, the association studies are trying to find what protein is associated with the outcome. Predictive models are trying to find not individual characteristics, but a combination of characteristics that collectively gives answers about a patient. So predict the outcome for a novel individual. Another issue is univariate versus multivariate. Much of biostatistics looks at a single variable and tries to find, is this important by itself? Whereas the thing we're interested in is combinations, is looking at combinations of features that best characterize who's going to have which outcome. And so, again, design next experiment and understanding etiology are really important tasks. Personalized medicine. Personalized medicine is really asking the question of, can I personally say what's best for this individual? What happens to this woman in this case? And that's where we're coming from. So that's a second theme I'll mention once. The goal is prediction, not association. Both are important tasks, but the machine learning perspective is looking about the predictive task. Now, there are many tools that can be developed from this technology. SVMs and logistic regression, some of the deep nets, everyone's heard about those. The tool that actually worked for this task was a decision tree. And they're going to be about 80% accuracy. I also will remind the clinician that, remember I mentioned beta carotene and said, this is a worthless feature. It has almost no correlation at all. It's negative 0.019. It doesn't say anything about disease. Well, it turns out it was important for the decision tree. It was essential to building, even though it was uncorrelated in general. So again, that shows some of the contrast between feature selection that's done and the tree and the tool itself, because the feature selection process, like the biomarkers, they said this can't possibly be a biomarker. It's so worthless, but there it is. Okay. Okay. So let me go on with the story about we want to classify that predicts correctly. And what does predicting correctly mean? Well, one intuition is, well, I train on data, I'm going to test the same data also. No. Correctly means it works on patients I haven't seen yet. The patient I've seen, I know the answer. It's ones I haven't seen that I care more about. And once again, that's not a member of the patient I trained on. Again, the learner hasn't seen this. So is it just guessing or is it magic? Remember the hat I had? So again, I tell a little story. Again, another narrative that I think is pretty helpful is to think about the following story. I want to build a clinic here in Edmonton to diagnose breast cancer. So the clinic is running, women come in, get diagnosed, and I get to actually see the outcome. I built a data set of say 200 patients. And after that's done, there's a little bug right there. After it's done, I take this training data and I build a classifier from it. And I want a classifier called C that by running a learning algorithm L on the data set D. So I want the classifier to do well in the data trained on. Maybe not perfect, it's not a subtle thing, but I have to do well in that type of data. So once I've done that, that's the training part. Now the performance, which I care about, that's going to be done on patients, on patients that come later to the same clinic. Okay. So now the issue is, what type of patient is this? So perhaps this patient was someone that I've seen before. It was a type of patient that has occurred many times before. And so if it's occurred before many times, I've probably seen it. So to be more concrete, I should mention I'm a little confused. I'm used to looking at that. I'm used to looking at that screen. I'm seeing my little screen here. That's why I'm squinting at it. Okay. So imagine to give more details, I have 200 patients in my training set. And imagine this type of women I'm talking right now is like 1 in 10. So if I have 200 patients, and this is a 1 in 10 type of patient, I've probably seen 20 subjects like this person. The training set has probably seen 20 individuals, which are similar enough to this. Oh, that's about me. Okay, I've been using the mouse to point, forgetting that it points this way. See, I'm used to walk around. So I'm thinking about these patients over here. So if I have 10% of patients look like this woman, notice about 20 patients I've already seen, which means if the classifier that's designed to do well on patients I've seen before, if it gets them all wrong, that's a big hit. That's 20 wrong. That's 10%. So chances are a classifier does well on patients from this data set will probably do well on women like this. Great. So common patients are probably patients that if are common, that means they're in the data set, which means it's probably going to be correct on it. That's part of the story. What about uncommon patients? Patients that I haven't seen. So to be concrete, imagine I've got a patient that's a 1 in 10,000 case, a very rare case. Well, a data set size 200 won't have, unlikely to have a 1 in 10,000 case, which means it won't be the data set, which means the learner that was training this data hasn't seen it. They might still get it right, but it's also pretty possible it won't get it right, it hasn't been seen, which means the classifier based on data may get it wrong. Well, it's unfortunate. I don't want to make any mistakes, but that's probably what will happen. So uncommon cases may get wrong, but they aren't very common. What's common in the training set won't be common in the performance set either. So it's not that big a loss in terms of the sheer numbers that you look at. So I want to just comment before I leave this point that, oh, that's terrible. It's hard about machine learning. Got it wrong. It's not a statement about machine learning. It's a statement about the statistical process. Many people here are currently residents and they're following their clinician around and they're seeing what the clinicians they see. And so in the course of a year of practice, they will have seen a sampling of the population. They also will just see a sampling of the population. They also will just have seen a subset here. I do have a pointer. Let me get my pointer. My apologies. I keep forgetting I can't wander around. Oh, okay. So now the sample over here, so as clinicians as your resident, you will have seen some patients, but not unrepresentative samples. So medical students will also make mistakes, as do senior clinicians as well. So again, it's just a factor of what you've seen in the past. Okay, so me and the narrative make a quick comment that the word predictor is confusing for the first year, because to me, as a machine learning person, predictor means like a support vector machine or a deep neural net. The word predictor also often means just a single feature, that this feature is a predictor. So that was a source of confusion. Another quick comment is the type of task, is it screening or diagnosis or treatment, and just a quick little diagram here that if you're making one decision, decision about the treatment to administer or decisions about what the diagnosis is, that's a machine learning type of task. But you can think about multiple decisions or one decision, talking about whether you deal with interactions and so forth. It gets more complicated for different things. Just some issues to think about as you're defining the task you want to deal with. Okay. Another thing I've observed is a few people in the room know I believe it's survival prediction. And I realize that a lot of doctors say, if something happens or will something happen, will this patient develop breast cancer? And I want to translate to a question I think is easier to answer. Not will she develop breast cancer, but when will she develop breast cancer? And if the answer to the question for this particular woman, if she develops breast cancer 100 years from now, that's not a big deal, right? Something else is going to be more problematic first. So then also the training set, if I observe a whole bunch of patients, some with breast cancer, and here's a 50-year-old woman who does not have breast cancer, typically that's not a negative instance. I'm not saying she's never going to get it. All I'm saying is she hasn't yet got breast cancer. So this would be a censored individual. So unlike a lot of problems can be viewed more naturally as a survival prediction task. That's just my own policy. Okay. So now I'm going to drill into the issue about the training data. And this is something that I have lots of points to. So you remember this picture I showed about historical patients being used to build models that are being applied to individuals, to novel patients later on. So let's talk about this training set. So there's a set of features that are being used. There's a label applied. There's a training instances that this is kind of distribution. And there's also the label for those. And look at things to say about all four of these different boxes. Here's the feature set. So the features, those are characteristics that define in this case, the woman or the patient we're dealing with. So it might be physical measurements or lab results or omics data or imaging data. They're all features describing that individual. So one thing to think about that's often missed in my initial meetings with clinicians is they see features whose values are available at the time that we're making their decision. So it can be things available at time to make a decision about the diagnosis of treatment, or things in the past that's eligible. So blood tests today, blood tests for the last year, whatever prior hospital visits are all eligible characteristics, but not future data. You're not allowed to ask questions about tests I'm going to administer in the future, or what treatments, the efficacy of treatments, or length of hospital stay. I don't know that when I'm making a decision when a patient's entering. So I know crystal balls. So maybe draw a picture of this. There's going to be a time a decision is being made in this performance system. At that time, start a treatment or entering a hospital, you get to use everything known before. Blood tests and genetic information, as well as information known that was known earlier from prior visits. All that's legal. The prediction can be about future things. Well, it can be about the current situation, but also you can ask questions about, will this patient develop a particular disease the next year? You can ask about that. But of course, the data used to make that decision is data I know at time zero. So again, I get to ask questions about future events. Well, the data I used to make that decision is based on data I know at the time when the decision is being made. Okay. So predictions can be about future based on data that's known now. How many features? Well, I talk with the clinician. For sure, something's not important, eliminate it. But if it might be relevant, include it. And let the machine out and decide what to include. And again, you can think about the one situation where there's a single fixed set of features, like single clinical set of clinical features. It might be a large set, like the omics or imaging data. That can be a much larger number of features, or thousands, millions, tens of millions of different characteristics. It also can be a small number of features, but there might be multiple things like temporally arranged, like previous electronic health records, or natural language, which have arbitrary long sequences. So again, the easiest small fixed number of features, but let's talk about other cases. There are ways to exploit high-dimensional data using topic models or non-negative matrix factorization to try to reduce the dimensionality. This main trick is to transform variable number to fixed numbers in Markov models and RNNs and LSTMs and so forth. So that was the handle, but this gives an idea of the number of features. What about the training instances? So again, it's a subtle point, but I want to repeat it. You have a performance task. Think about that. Let that guide the sort of features we want to collect. I'm going to talk about that. And then another issue about different distributions. So let me motivate this. If I have a trained model that appears accurate, then it's going to work everywhere for any patient anywhere in the world, right? Yeah. Well, maybe. Maybe it depends on training data. If I want a predictor that works in Edmonton, perfect. Train on Edmonton patients. Yeah, we're in Edmonton, we can do that. Will this model work on Ottawa patients? Well, it might work. Of course, it's not guaranteed to. It only will work if you can guarantee me that everything relevant about Edmonton patients, about patients that's relevant is the same in Edmonton and in Ottawa. If you really want to predict if there works anywhere in Canada, then you should train outpatients from anywhere in Canada, from everywhere in Canada. You should take Edmonton, Ottawa, Montreal, Toronto, yada yada. I mean, it's obviously you say it out loud, but it's amazing people say, I've got data from here, and I'm sure it's work everywhere. Well, maybe it will. But the statistical guarantee underlying it says you train from a distribution. If you want it to work on a certain distribution, make sure you train on the same type of information. Again, a little story here. If my training population looks like this with positives and negatives, I can easily build a dividing line here. But if my performance task data looks the same, it's probably going to work. The same dividing line is going to work. Perfect. But what about this situation? I trained this data before, but my performance task is different in some fundamental way. So here, this dividing line is not going to help at all for distinguishing positives from negatives. Just look at it. It's completely wrong. Okay, so why do I mention this? Well, look at the situation where, for example, women who suspect will have breast cancer. That's what I want to deal with. And if the women who suspect to have breast cancer, some will and some will not. So this is a pretty standard sort of story. And I could build a line like this. But imagine my training data was different. My training data was actually had different characteristics. Instead of looking for women who suspect to have breast cancer, do not. I'm sorry, I said this backwards. My apologies. Let me back up. Sorry. No. So I'm just getting flipped. So if the performance task is women who suspect they have breast cancer who do or do not, you should train on that. And the earlier study that I can't back up to for some reason. Okay. The earlier study was actually, I misworded it. There were women who thought they had breast cancer who did versus a random sampling of patients that had no suspicion of breast cancer. I'm sorry, I misread the slide a moment ago. Okay, let me just keep going. Now I'm all gummed up with. Okay, sorry about that. Okay. So consider the performance task. I really should be thinking a woman who suspects they have breast cancer, who did it or not. Be sure to train the same type of data. So again, the distribution of training data should match the distribution of performance. So when you train your training data, look at the context of how it's going to be used in the future and use that. Okay, now remember the theme, focus on the performance task. So what if the data is different? What can you do about it? Again, just quickly, imagine I had Jakarta data I was training on, looks like this, and I have performance data I really care about Edmonton. What can I do about it? Well, there's tools like important sampling. If people know about that tool. There's ways to reweight the individuals that look more like the Edmontonian population. You can do things with that. Again, I'll go very quickly through that. Just there are tricks you can use if you know the distribution of the population. It can be more subtle if there are latent features that characterize the difference. But let me just keep going. Okay. Because covariance shift and ways to handle individual treatment effect with selection bias. There are ways to compensate, but you have to think about it. You have to be careful about it. It's worth being aware of these issues at least. Okay. Again, same thing. Okay. Another issue is what if there's more than one label? So often with psychiatric drugs, there's drug efficacy, and there's also things like side effects. And here you can say, here's a formula of how to look at how effective this treatment is, combined into one score. So for each patient, I would want a single score that describes it. But why do that? Why not define two different models? One that predicts drug efficacies, one that predicts side effects. And now, when you're deciding what treatment to administer, you can ask the patient or the patient's candidate or the general hospital, how do you want to trade them all? So I started in one simple model that has a single number. I can learn multiple models and apply them as appropriate. So for example, if you think about HAM-D score, for example, it's various different factors that describe the patient. It's a single context. So a HAM-D score might combine so depression. looks at things like anhedonia and insomnia, self-destructive thoughts, and so forth, and gives a single number about discharge it. Well, why give a single number? Why don't you relate the different sub-numbers, different sub-contexts? So, for example, you have a score for insomnia and anhedonia, because perhaps a drug that works really well for insomnia may have no effect at all for insomnia. And so if all you have is just the sum of scores that involve both insomnia and anhedonia, you'll be sensitive to the fact that this drug only works for anhedonia and not for insomnia. And so you won't know the drug efficacy because you've hidden it into a single characteristic. Why do that? Why don't there multiple predictors and then talk about the different drugs and how they affect different parts of it? So that's an option you have. Okay, let me now talk about the label. So a label training data set provides a value, a label for every instance. And that's what the learner tries to build a model that can predict that. So what should be some of those labels? So one question, can go back to depression. So who has depression? You could ask this clinician who might say these are the values, yes, no, and yes. But a different clinician might give a different answer. And now they differ. Now what do? Which of the clinicians should you emulate? The one who wrote the most recent article, the one who can speak loudest, the one who's got more seniority? Well, why are we doing it anyway? Why don't we have an objective measure? So it doesn't matter which clinician you're talking about. Again, statistically, the kappa score for psychiatric evaluation is like 0.35, which means there's a lot of disagreement amongst clinicians. Why does something like HANDI, which is a score you can just, or the Beck score, it's like you self-administer. Scores like that are unambiguous. They're based on the patient itself and not based on the clinician evaluating it. That's my third theme of verified labels. So what treatment to give? The same questions. You could ask one clinician to get answers. A different clinician may give a different set of answers about different treatments, about SSRIs or BSTs or cognitive behavioral therapy. Same sort of answers. You should think about objective measures. You can ask, for example, the treatment that's best, define that as being the treatment that is most effective for 6 weeks later. So look at the given treatment and look at the HAMD score in 6 weeks. And now again, it's a verifiable label. So now you can ask questions like, what treatment should be administered to the patient rather than which one happened to have been? Well, now you can think about, here's the 3 different patients I talked about. I know the outcome that happened for certain specific treatments. There are tools like counterfactual reasoning, and I talked about selection bias earlier, maybe ways to counter some of that. And maybe you can make a prediction of what would have happened under the other treatment options. And now you want the label to be the one which would have given a yes answer, to have a suspicious good score. You know, I have a whole lecture on this knowledge of actionable objective labels, but that's a different talk. So again, verifiable labels is the theme here. Okay, so I'm starting right at time, so I'm going to go a little bit faster. So instead of just do what I do, instead of just emulating a particular clinician, okay, I should think about, can I say that? Let me just go a little bit faster. So another question is, how do you go about evaluating a model? So we actually define the tasks you care about. You want to talk about the input and the output. And also critically important is, what does it mean to be the right answer? What are you actually trying to do? And it turns out that's a very subtle question also. That's more subtle than you would have thought. It's just obvious, right? You're trying to get the right answer all the time. Well, it's more subtle than that. You want to get some performance measures, which you can actually evaluate, have an objective evaluation for. Or have a real number, so I can compare to different models. If these different models have different scores, if I had, for example, 2 numbers that define a model, the efficacy, I won't know which one's better. If I look at sensitivity, precision, and recall, then if this is higher precision but lower recall in this other model, which one's best? I want to give a single model that gives an answer. Okay. Let's go a little bit faster here. If we're thinking about what you really want, with diabetes, and you want to keep a patient's blood glucose between 4 and 8 of the units here. And why? Well, if it goes under 4, the patient risks, being hypoglycemic, might pass out, have worse consequences. being above 8, they might go blind of amputation, so you don't want that either. And injected insulin can reduce the blood glucose level. So the goal of policy is always to prevent hypoglycemia. If that was the goal, always prevent hypoglycemia, that is really, really easy. You never give insulin. Well, that defeats the whole purpose, right? Okay, so I also want to reduce A1C. Okay, well, that's my goal. Give lots of insulin, right? That's easy. Well, no. I need to combine the criteria. Well, the doctor said, well, I can't do that. To which I respond, you are doing it. You're doing it implicitly. You're making decisions about a patient. That is some formula. If you just say, it kind of feels right to me, then I can't model your feeling right. Give me some objective criteria. Make it explicit. Have a particular evaluation criteria for what the blood glucose is, how bad it is to be hypoglycemia. You can have it quantitative to be able to do a reasonable evaluation. Okay. Let me go faster here. Another big issue is, what if I have imbalanced data? So let me just get back to this and just say that often the good news about the world is most people don't have most diseases. That's a good thing, right? Which means if you have a training population doing a screening test, you might have less than 1% has a disease. Excellent. Which means that if you just say everyone's healthy, you get 99% accuracy. That's great. This is easy. But is it wrong? Well, let me point out that if every false positive, every false negative had the same penalty, that's great. You got 98%. You're actually measuring what you care about. What is wrong with that approach? It's just that there's different costs. Again, some of the slides I skipped talked about that. There are different costs. A false, if you tell a woman who has breast cancer, you're fine, go home, and a year later she dies of breast cancer that could have been curable. That's horrible. By contrast, a false positive, we're thinking of breast cancer, why don't we do a more invasive biopsy? That's not free either. There's pain and there's dollar cost, there's pain, there's the stress of the whole process. But there's a cost for false positives, false negatives. They're not the same. If you can quantify that, you could say what the loss is. And so now it's like 50 times worse for a false positive, false negative. You can actually quantify that and say, this is why I'm doing what I'm doing. And so accuracy is a wrong measure, not because it was easy to give the answer, but because it wasn't measuring what you care about, which is some sort of cost of what would happen next. Okay. Same thing over here. I mean, people can try to measure F1 measure or kappa score, AUC. All these are things you can do. But why do that? Why don't you instead say, what am I really trying to do? What's a real objective criteria? Let me optimize that. You need to have some sort of cost value. I should caution you, I worked with dozens of clinicians. Not one of them could tell me ahead of time what the actual trade-off of false negative. They can say, it's much worse being a false negative than a false positive. Is it 3 times worse or 50 times worse? Yeah, kind of, Russ. But again, it's a hard question. But if you want to actually do science, you have to have quantitative measures. And that's important to have. Okay. Again, focus on the performance system. I want to point out that simply say, the goal is just to say, is there a signal in the data? That's all I care about. Well, if that's what you want, you're doing biomarkers. Biomarkers. If you want to actually figure out how to help clinicians, you need to actually help clinicians solve their problem. And getting some idea of what the scores would be for false positives, false negatives is essential here. Another issues explanation, and I think from what I'll just skip over one. Saying that there's a lot of interesting questions about what is an explanation? What is a feature? What is a feature selection? And what intuition is, I'm going to select features which are causally related. And that's great if you can do it. But if you have observational data, you probably are not finding causes. You're probably not even finding things which are necessary. You find this a sufficient set of features. And there's a whole long litany about that. And remember, I mentioned earlier, there's an example about this decision tree here, which included beta-catenin in the nucleus, which was not a biomarker, but still was really important to include in this particular case. Okay. So let me just say that I've talked about many machine learning algorithms will involve a some sort of feature selection as a pre-processing step. And find features that help with the learning process. Oh, well, that's the same with biomarkers. I should find biomarkers first. Well, again, I gave you an example where it didn't work a moment ago. Let me say a little more about the issue here. The word does mean different things for different cases. So again, I think about the feature selection for biomarker discovery as like trying to find building a fast car. There's a feature selection for the machine learning applications like building a sturdy car. And so the idea that if I build a faster and faster car, that doesn't get more sturdy, right? They're different goals. And so one, again, another narrative I use to describe this is, imagine I'm looking at, I'm trying to build a predictor of efficacy of a certain breast cancer drug. It turns out that estrogen receptor is correlated with the efficacy, as is progesterone receptor. They both are correlated with the outcome, and they're also correlated with each other, right? Which means a machine learning algorithm would try to find what a sufficiency would focus on one of these, and that's what decision trees or lasso would do. But of course, if I figure what's effective, what's a biomarker, they both be biomarkers. A different example would be looking at the health of a baby in utero. The mother's blood type and the father's blood type are things I know. It's easy to give examples where a baby's health depends on whether the mother and father have the same blood type. So you can give extreme examples where the health of the baby is completely independent of those blood types, and also completely independent of father's blood type. So that neither are biomarkers, but the health of the baby depends on both of those. Okay. So in this case, a machine learning algorithm without both of them, and they're neither are biomarkers. And again, this little example shows that the overlap is there are things on both sides. Okay. Okay. And let me let me spend one more question about the objective criteria that I sort of mentioned. So I'm going fast towards the end. The actual objective criteria, many clinicians say, that's your job, Russ. You tell me what I'm trying to do. To which I say, no. False positive, false negative. You're the person talking to the patient. You're the person who has to make the medical decision. You have to decide how bad false positive, false negatives are. You can talk to me about it. I give you hints about it. We can talk about it, but that's a medical question, not a machine learning question. Think of the performance test. What are you trying to do? And how should you evaluate that? Again, focus on performance task. Okay, let me just, there's a whole body of work that talks about how you actually built the third part, which I'm going to skip right now, go to the very end. Whoops, well, that's, okay. Okay, well, this, sorry, I said go to the very end. Oh, okay, I'm sorry, I had hyperlinks that are, go really fast. Sorry about that. There's a hyperlink there that I should have skipped along. I just went really fast. I see what happened. Okay. I had a hyperlink that's all right. Let's just look what's going on. I got 3 pictures. I have hyperlinks. Now, is this going to work? Well, I know it's going to. All right, summary as promised, right? Okay, so you guys followed all that? So here's some of these. So let me just talk about a few of them. Right? I mentioned 3 themes. Focus on performances. I said that a bunch of times. That's what you're doing machine learning, yes, for the purpose of building a deployed tool. Talk about that deployed tool. Let that guide your decision. What data do you want? How do you evaluate it? What do you try to, how do you trade off positives and negatives? All that comes from thinking about the performance tool. I talked about prediction versus association and about verifiable labels. So again, some themes, right? Performance, not learning, prediction, association. Training data should match you should get training data by thinking about the performance test because it matches that. And you want the true objective label and objective outcome. You want not just match what a doctor does. If the only way to verify what the true answer is based on a doctor saying something, then I don't care about it, nor do you. It should be based on an outcome that you can measure later on, which hopefully the doctors actually are familiar with. But let's just go to the outcome I care about. More comments about measures for evaluation, performance tests. They thought it's a medical decision on machine learning questions are all important. But I'll make the slide develop if you want to see later on, or in the party script. So let me just ask for acknowledgements. I'm a machine learning person, not a medical person. I get to work with some world-class people for all the different projects I mentioned. There are people who answer questions, are delighted to work with this and get good answers for many exciting topics. And I think I'll end here. Just 2 minutes over. Questions? My mask up, you come over.
Hello. So now we'll have a question period. As before, the rules are that in-person attendees can go up to the center mic, and online attendees can enter their questions in the chat, and one of the execs will relay it to Russ. Thank you.
Hi, Russ. First of all, great. Thank you so much for coming. And I think all of us really just wanted to keep listening. It was great. So I have a few questions here. So the first one is, what kind of ML technology are you most looking forward to seeing being integrated into the clinical setting?
Okay. So I was asked to repeat the question. So what type of machine learning technology am I most interested in looking at?
It's being integrated into the clinical setting.
Well, so again, there's machine learning algorithms, there's also a machine learned performance tool. So clearly one set of things that's been used already is some better microscopes, the tools that can give more answers to the doctors can use, like better, more effective tools for looking at imaging data or pathology reports. So I think that's happening right now. I'm most interested in seeing tools which don't just give intermediate results, but actually give predictions for the individual patients. Currently, it still is, again, like a better microscope, something a doctor can use as another consultation. I would like to see tools which actually say, here's my consultation based on these reasons, and go forward with that. What technologies will lead to that? Well, deep nets and so forth are all different things, but I think you're really interested in what do I see happening next. And obviously, another thing would be situations where computers can handle very fast, like in an ER, in a situation, an operating, and I'm at the operating room, which things are going very quickly, having lots of monitors and get reliable information would be something that would be critically critical to clinicians as they're working.
Awesome, thank you so much. I'm going to say another question here, but for any of our fellow execs or anybody, if you do have a question, just literally on the line.
Okay.
So another question is, what are some of the greatest barriers you've seen in trying to apply machine learning tools to a clinical setting?
Another great question. Well, one, I need data. I mean, that's just a statement about statistics. You need to give me the context, what's going on. I'm fortunate to be in Alberta, right? We have one health system here, so there's a lot of people potentially. I'm also really lucky. I gave a list of my colleagues. If they do the hard work, collecting the data, doing the ethics, getting all their forms filled out, getting the data, making it available. But getting the data is critical. Another thing that I would like to see is, I talked about accurate outcomes, objectively actionable decisions being made. Much of the results I work on is because it's based on data that was labeled by clinicians. Oh, I'm sorry, I forgot to repeat the question. Sorry. The question was, what are the obstacles? Sorry, not good. So the question now is, how can I help? How can I get more data? Is one thing that will be useful. Getting the objective outcomes means following patients and seeing what happened later for decisions that are made based on that. Very few examples of that are available right now. Most is diagnostic based on a human clinician. I'd rather do prognosis, which would be, here's an outcome, and this is why this treatment was better than that for this class of individuals. But again, it's exciting. People are, look at the people in this room. You guys are all in the mode, right? You're going to understand how machine learning can help. You're going to pave the path to make this all possible, which I'm really excited to see happen.
Awesome. Thank you so much.
You were mentioning about those biomarkers that patients see in the eye. The difference between that with prediction. Also, you mentioned that these sufficient factors might be the one that are causally related, but I mean, they might not be necessarily the ones that have association.
So the question, I think you're asking about where does causality fit into all this?
Yeah, I was thinking about is causality helping in that sense, or is it possible based on the data that are available to think in terms of causality?
Well, great question. If someone gave me the causal factors, if I had divine insight and knew that, or if there was real studies that did it, I would, that's goals, right? That's wonderful. That says what actually led to this happening. And I might still need machine learning for other parts of it, but that would solve a big part of the problem. Unfortunately, that's very rare. I mean, typically we have observational data sets. Here's what, standard examples, right? I get to see what doctors actually applied. And that's good because they do a good job. What if they did something different? Well, I can only guess what would happen if they didn't do these other different things. If I had the causal factors, I would know this is not relevant or that it wouldn't help. So how can I help in that context? Well, if there are randomized control trials, I can give some evidence that goes forward. Obviously, the biomarker studies, their goal is finding causal relations. Their goal is, if I knock this out, they do interventions. They can see, yes, this person did not get the disease when I knock this out or when I amplify that. All that's great. So I'd love to see more causal relations and see them happening. The data we have doesn't allow me to get that. If you have it, let me know. Let them play with it. If you don't have it, then don't think that the fact that a machine learning algorithm point to that feature and that feature, that those features must be causal, because that tends not to be true. It's very intuitive that I saw this happening and therefore it's related. The standard examples right now. One of our colleagues says that obviously bringing an umbrella in your car causes the car to crash. Well, think about that, right? The umbrellas in the cars because it was raining, and that could, and there's a lot of examples. Again, that's a simple example, but a lot of times you find things related to the treatment of the disease, not the disease, or related to other covariates, or other factors which are with respect to the population. People eat certain foods tend to get certain diseases. That's not because the food caused it, but because they're part of an ethnic group that eats these foods. And the ethnic group was defined by different alleles in the genes. And that was what led to the disease. So finding that things co-occurred doesn't mean they're causal. Yeah, please. Yeah, go for it. But yeah, whatever. It's just column 3 on my list also. I don't understand. It can suggest. Yeah. Good question. So again, the question was, I gave an example of where something which had very little correlation actually being important to my model. So again, a few sort of comments about that. So one of them is, it still wasn't causal necessarily, but still was the most important, and it's ended up being used in giving and being part of the correct answer. An unanswer that was correct. It was sufficient to be part of the tool. Why don't I ask doctors what's cause related? Well, I do. Well, first, the fact that they included that as a feature meant they thought it had some correlation, which is great. Some reason to believe it would be helpful. The fact that it had very low correspondence means that over the whole population, it was very unrelated. But amongst the people, I've forgotten the whole tree, but amongst the people who had no lymph nodes and who had alpha catenin was this and who had this and that, and who had all these other factors, amongst that subpopulation now was critical. So the fact that overall it might not be. Imagine a feature that's highly positive for half the population, highly negative for the other half. would have zero correlation overall, which doesn't mean it's irrelevant. It means that I had to find this separation. So again, the fact that the learning algorithm identified features which it used doesn't mean they're cause related. And the fact that clinician says, I think it's related, again, I work with lots of clinicians. They're brilliant, they're wonderful, they're well-read, they're articulate. The state of the world's knowledge is incomplete. I mean, we've seen with COVID that the CDC, for all the best intention, the decisions were different times as more data came in. And that's not because they were wrong, it's because the data so far said X, and then it said not X later on. And the state of the world's knowledge about many diseases is still partial. It's exciting. I mean, as a human being, I wish we knew everything about the world. As a machine learning person, I get a career because I get to sort of explore things that haven't yet well understood. Great questions.
So we have a few great questions, but we unfortunately have time for one more. So can features that are uncorrelated within the entire data set be correlated within a single class?
Yes, well, I gave, so the question was, if a feature is uncorrelated to like the whole data set,
yeah, can
it still have a correlation with a subpopulation? And the answer is yes, right? Again, I gave some examples earlier, but certainly the beta-catenin in the nucleus, there's a subclass where that actually did make a difference, and it would be a correlation within that subclass. You also could imagine situations where I've got men and women, and the overall correlation might be zero, but again, for women, it's positive correlated, for men, it's negatively. So examples like that are abundant.
Awesome. Thank you so much.
I'll unplug and leave.
Thank